Well, thanks to the organizers for inviting me to participate this conference. And I'm, like Dr. Dulay said, I'll be covering disorders of brain-gut axis. And my goal over the next 30 minutes is to highlight some of the abstracts that I thought were particularly notable or exciting from this year. I am going to focus more on lower disorders. We had some disorders yesterday on upper GI motility. And then my goal was to summarize the key findings from these abstracts, and I'll provide a little summary of strengths and limitations as I interpreted them. So the first abstract I wanted to discuss was this, the colonic biological clock and predictability of time of bowel movements during treatment with a vibrating capsule, Vibrant, in patients with severe chronic idiopathic constipation. And this was an abstract submitted by a group of collaborators from a number of different institutions. So a little bit of background, healthy subjects tend to defecate after activation of high amplitude propagating contractions. And this usually occurs after awakening or after a meal, and it's a pattern that's attributed to the colonic biological clock. And this is regulated by our circadian rhythm. But the circadian rhythm and the diurnal distribution of bowel movements haven't been thoroughly investigated in patients with chronic idiopathic constipation. And then there's prior research recently demonstrating that this vibrating capsule can significantly increase the number of complete spontaneous bowel movements compared to placebo. And this is what led to the FDA granting marketing authorization for this capsule last fall. So for this abstract, the aim of the study was to examine diurnal distribution of complete spontaneous bowel movements in patients with severe CIC who were treated with a vibrating capsule or compared to placebo. This abstract did present post hoc analysis from the original phase 3 data, and the analysis focused on the subgroup of patients who had severe CIC, and these were individuals who were defined by the absence of complete spontaneous bowel movements during their baseline period. And for the actual study, these capsules were taken at 10 p.m., and then they were programmed to be activated about 14 hours later, so at noon the next day. And the outcomes of interest were time to complete spontaneous bowel movement and complete spontaneous bowel movement responder rate, which was defined as the proportion of subjects who had an increase of at least 1 or 2 CSBMs for 6 of 8 treatment weeks. So the analysis, this subgroup of severe CIC included 175 patients of the 312 who were originally enrolled in the phase 3 trial. And in this figure, you can see that CSBMs tended to occur later in the day. The x-axis shows time. And this was present in both the active treatment group and the placebo group. When they compared the cumulative average, this was significantly higher for patients who had received the vibrating capsule compared to placebo. And this difference occurred between the hours of 1800 to 2200 or 6 p.m. to 10 p.m. Then they conducted a stratification analysis based on cumulative number of CSBMs between that time frame. And this analysis did reveal significantly more CSBMs with the vibrating capsule compared to placebo during this time period. And there was a significantly greater number of responders with severe CIC in the treatment group compared to the placebo group. And this pattern was consistent for the entire phase 3 population as well. So in conclusion, these data show that individuals with severe CIC tend to move their bowels later in the day, suggesting that there may be alterations in their colonic biological clock. The vibrating capsule actually improved constipation by increasing the number of bowel movements that occurred later in the day. And so this information is fairly novel and important, thinking about optimal strategies for patients with CIC and thinking about the fact that they may have an abnormal colonic diurnal rhythm. So strengths, the things that I liked about this is that these are data from a rigorous multi-center prospective trial. They did target a subgroup with CIC. Obviously, limitations are this is data from a post hoc analysis. They didn't specifically assess physiological features like transit or pressure that might also provide direct insight into circadian rhythm. And of course, we don't have a direct comparison with bowel movement activity in healthy controls. The next abstract I wanted to discuss was this that came out of the UCLA group. 3D imaging and computerized quantitation of sigmoid mucosal biopsies show correlations between the proximity of mast cells to sensory nerve fibers and IBS symptoms. And this was one of the abstracts presented at the Research Forum for IBS Pathophysiology. Colonic mucosa is innervated by extrinsic efferent and afferent nerves, as well as intrinsic enteric neurons. And together, these modulate motor, secretory, and sensory functions. And there is a complex interplay of nerves and immune cells that may be altered in irritable bowel syndrome. So for this study, the investigators set out to accomplish 3 aims. The first aim was to establish an approach for 3D imaging of innervation in colonic mucosal biopsies and establish an approach for computational quantitation of nerve fibers, enteric glial cells, mast cells, and the proximity of mast cells to these nerve fibers. They then wanted to compare these measures between healthy controls and patients with IBS, and then assess the correlation between these parameters with symptoms, including the IBS symptom severity scale, abdominal pain intensity, and unpleasantness. So for this, they took sigmoid mucosal biopsy specimens from 12 healthy controls and 15 patients with IBS who were very similar in terms of their age and their sex distribution. These were then processed for clarity, which is a tissue clearing technique, and it transforms tissue into a nanoporous hydrogel tissue hybrid that helps to preserve structure, protein, and nucleic acids, and it allows for immunostaining. And so then they conducted single or double immunolabeling with 10 marker antibodies as shown on the table, and these are markers for nerve fibers as well as enteric glial cells and mast cells. They then used Z-Stat confocal images to generate 3D images, and they used image analysis software to quantitate the densities of nerve fibers, enteric glial cells, and mast cells, and also to quantitate the proximity of mast cells to nerve fibers, which was expressed as the percentage of mast cells with shortest distance to nerve fibers of the total mast cell population. And these are some example images. So when they went to compare the densities of these between the IBS and the healthy controls, they did note that the densities of nerve fibers, enteric glial cells, and mast cells were not significantly different between the groups. But there were certain markers like calbindin immunoreactivity and choline acetyltransferase immunoreactivity. These densities tended to be lower in patients with IBS, but it was of borderline significance. In the IBS subgroup, VIP and neuropeptide densities were negatively correlated with symptom severity scores, and neuropeptide was also negatively correlated with abdominal pain unpleasantness. They then went on to assess the proximity of mast cells to these nerve fibers, so how close mast cells are and how many are in close proximity. And this parameter was positively correlated with symptom severity scores as well as pain and unpleasantness. And then specifically in IBSD, they also showed similar relationships, a negative correlation between VIP and neuropeptide immunoreactive densities with symptom severity scores, and a positive correlation between the percentage of mast cells in close proximity with nerve fibers and pain intensity. So in conclusion, these novel 3D imaging approach and computerized quantitation of colonic mucosal nerve fiber densities and immune cells showed differences between patients with IBS and healthy controls. And it appears there are correlations of nerve fiber densities and the mast cells that are in proximity to these nerve fibers with IBS symptoms. And findings support the concept that there does appear to be altered peripheral neuronal signaling in IBS. And this is particularly exciting in that, again, these are potential tools that may serve as objective biomarkers for IBS for symptoms or even predicting or measuring therapeutic responses. So I thought the strengths of this I really like this in that it was a novel approach to examining not only the quantitative relationship between the enteric nervous system and immune cells, but also a spatial relationship, and they tied that back to symptoms. They did use validated tools to assess clinical correlations, and they did also include specimens from both healthy controls and volunteers with IBS. Of course, this is a pilot study, so there are some limitations, small sample size, there was some random sampling. This may benefit from longitudinal data, including collection of specimens during symptom exacerbation or during periods of relative quiescence. The next abstract that I wanted to highlight was this from the Mayo Group. Small intestinal microbiome dysbiosis may underlie abdominal pain in patients with disorders of gut-brain axis interaction. So the current paradigm when we think about the small intestine is that small intestinal bacterial overgrowth is often considered as a cause for symptoms, but there is a growing body of evidence suggesting that alterations in microbial composition rather than overt bacterial overgrowth might underlie some of the symptoms that we see in patients with disorders of gut-brain interaction. So when we try to do preclinical studies, human stool is most commonly used to recapitulate the human gut microbiome in germ-free mice, but it's still unclear if stool is really the best input sample for this, or if it can even recapitulate the small intestinal microbiome. So for this abstract, the authors or the investigators set out to establish a mouse model that could best replicate the human small intestinal microbiome. And they also wanted to investigate the influence of the human small intestinal microbiome on visceral sensitivity. So they collected duodenal aspirates and stool specimens from healthy controls, as well as age and sex matched patients who had abdominal pain but did not have SIBO. They then took germ-free mice and gavaged them with these samples from either the small intestine or the stool, and then maintained them in a controlled setting. And then after 4 weeks, they then took the small intestinal contents from the mice and then processed them alongside the human samples for 16S rRNA gene sequencing. And then in a subset of mice, they went on and conducted further experiments to measure visceromotor responses to colorectal distension, to different pressure measurements. And this is a commonly used approach to try and capture pain using an animal model. So this is just a plot showing analysis of microbiome composition. So beta diversity-based principal component analysis here showed that the small intestinal microbiome of mice that were colonized with human small intestinal aspirates more closely resembled the input samples. So about 80% of human small intestinal species were present in the mouse. And you can see that the green portion there is closer to that purple, which represents the mouse and the human. And then in contrast, the small intestinal microbiome of mice that were colonized with human stool were less similar. So there was about 40% of species that were retrieved. When they went on to do their experiments looking at visceromotor responses, they did observe that mice who had received small intestinal contents from patients with pain had higher responses to colorectal distension. So this is a marker of visceral sensitivity, and you can see that at the various distension pressures. The blue represents the mice who received their input from patients compared to the green mice who received their input from healthy controls. They conducted sequencing of the human and mouse small intestinal contents from one abdominal pain patient to healthy controls. They did find a Shigella species in the human, the content from a human sample from a patient, and from the mouse small intestinal content. And then they further observed that the relative abundance of this Shigella species was positively correlated with visceromotor responses to colorectal distension. So in conclusion, the authors were able to confirm that human small intestinal contents are better than stool for replicating the human small intestinal microbiome in mice. Presence of Shigella species in the small intestine might underlie visceral hypersensitivity in some patients with pain and could represent a microbial target. Strengths of this study, I like the fact that they included healthy controls and patients with pain. They conducted a combined experiment of microbiome composition. They also measured visceral sensation to offer insights on microbial mechanisms for pain. And they analyzed both the small intestine and colonic microbiomes to try and identify an optimal approach to conducting these experiments in mice. Limitations, so 16S rRNA sequencing, which is commonly used, it can introduce larger bias when we're examining microbiomes of low abundant sites like the small intestine, so we have to keep that in mind. For this research, the investigators did use a very small pool of human input samples. And then, of course, we don't have direct assessments of the relationship between this potential taxa, Shigella species, and visceral hypersensitivity in pain in humans. Okay. All right, moving on to the next abstract. This was one on fecal incontinence from the Mayo Group, a double-blind placebo-controlled study of clonidine and colesevelam. So women with urge-predominant fecal incontinence may have a stiffer rectum and increased rectal hypersensitivity. And in a prior phase 2 study, clonidine increased rectal compliance and reduced sensation, but didn't actually reduce fecal incontinence in women with urge fecal incontinence. There appeared to be a borderline significant effect in women with diarrhea and urge FI. And we do know that up to 25% of patients who have chronic diarrhea or idiopathic diarrhea actually have bile acid malabsorption. So for this study, the authors hypothesized that clonidine plus colesevelam could improve fecal continence in women with urge FI. This was a randomized controlled trial that enrolled 59 women with urge-predominant fecal incontinence. They conducted baseline assessments for 2 to 4 weeks and then randomized them to placebo or to active treatment, which was clonidine plus colesevelam. This was a 4-week treatment course. And then during this period, they conducted symptom assessments of bowel symptoms using diaries and other questionnaires, and they also evaluated anorectal physiology. For the analysis, they analyzed the baseline data as well as the week 2 to 4 treatment data, and the primary outcome was the number of fecal incontinence episodes, and they had additional secondary outcomes as well related to symptom severity score, severity index, and fecal incontinence quality of life. So this is their table that shows the baseline characteristics. So as expected, the two groups were similar. On average, all the patients who were enrolled had moderately severe fecal incontinence. A total of 51 patients completed the study. And again, no significant difference in either their baseline characteristics or in their fecal incontinence parameters or their anal rectal manometry. Now, when they went on to examine change with treatment, what was interesting was that they noted that fecal incontinence actually improved with placebo, and this is shown here in the middle of the table. And treatment of clonidine plus colesevelam also improved number of episodes per week, but the only difference that they observed between the two groups was the fecal incontinence symptom severity score, not the other bowel symptoms. So the primary outcome of the study, which was greater than a 50% reduction in episodes, was not actually different between the treatment group or the placebo group. And among 21 and 30 patients who completed all 4 weeks of treatment, the change in the number of episodes was directly correlated with urge sensory thresholds in the treatment group, but not in the placebo group. So in conclusion, in this study, the investigators showed that over half of patients who were treated with placebo reported a greater than 50% reduction in the number of fecal incontinence episodes. The effects of active treatment were not significant compared to placebo, but clonidine plus colesevelam did improve fecal incontinence severity scores. And this is important because this is a tool that incorporates various features, including frequency, type, and amount of leakage and rectal urgency. They did note additionally that clonidine plus colesevelam was more effective in patients who had higher rectal sensory thresholds, which might suggest it could be useful in patients without rectal hypersensitivity. But future trials do need to evaluate the utility of these treatment in patients who have documented bile acid malabsorption. So the strengths of this, this is a prospective placebo-controlled trial. I did like this because we are lacking effective pharmacological treatments for patients with fecal incontinence, and this has a major impact on quality of life. The investigators did conduct detailed investigations of clinical symptoms as well as anorectal functions. Some of the limitations, we did see a very high placebo rate, and they also enrolled women with urge fecal incontinence, but not necessarily those with urge and diarrhea, which may have impacted their ability to demonstrate a significant difference between the groups. All right, this was another abstract I wanted to highlight. This was presented at the AGA Clinical Plenary, a randomized parallel group study of self-administered digital gut-directed hypnotherapy versus muscle relaxation for irritable bowel syndrome. So gut-directed hypnotherapy is effective for treating IBS, but access issues do limit its widespread use. And there are preliminary data suggesting that muscle relaxation may also benefit patients with IBS. So for this study, the aim was to compare the safety and efficacy of self-administered digital GDH with digital muscle relaxation in adults with IBS. This was a multi-center randomized double-blind trial that enrolled patients from 26 centers across the country. Patients were between the ages of 18 to 70, and they met Rome 4 criteria for IBS, but also had to have an average worst daily pain severity of at least 3 during the run-in phase. Patients were randomized to 12 weeks of treatment with either digital gut-directed hypnotherapy using the North Carolina protocol or digital muscle relaxation, and both were administered using a mobile app. And the primary endpoint was at least a 30% reduction in from baseline in average daily abdominal pain intensity. And they were specifically looking at the 4 weeks post-treatment, and they had other secondary outcomes of interest, including mean change in pain, stool consistency, and frequency. Oops. It's not working. I'm not sure. Is that okay? So 362 patients were treated and included in the final efficacy analysis. In terms of their primary endpoint, 30% of people who were in the GDH group met the primary endpoint compared to 27% of those who received muscle relaxation therapy. And again, this was the a priori assessment period, which was weeks 13 to 16. Move to the next slide. Okay. When they then went on to examine responder rate at different time points, however, they did note that a significantly higher number of patients treated with GDH achieved the response during the last 4 weeks of treatment or over the entire treatment. Next, please. And then there were no significant differences in secondary or exploratory endpoints during weeks 13 to 16. I'll move on to the next slide. Okay, so in conclusion, for this study, there were benefits observed with digital gut-directed hypnotherapy, and this is consistent with what we've seen with in-person therapy. Similar studies have shown symptom reduction with gut-directed hypnotherapy versus other control interventions, which usually do involve some sort of active treatment. And then the findings from this study support the use of a digital delivery of gut-directed hypnotherapy, at least using this North Carolina protocol. And treatment with the digital program did lead to robust improvements in pain and stool symptoms in patients with IBS, again, supporting its use as part of integrated care. Next slide. So strengths of this is a very large randomized trial with a rigorous study design. They did use an active comparator, and it's the first study to assess an all-digital program for delivery of gut-directed hypnotherapy. Some of the limitations, unclear effective durability, given the fact that there was a lack of difference during the actual post-treatment assessment phase, and it may be important to try and further identify clinical features that might enhance adherence or response. Okay, and then this is the last abstract, long-term effectiveness of 2 different carbohydrate restrictive diets in IBS, the CARE-IBS trial from Sweden, Magnus Simrin's group, and this was also presented at the plenary. Next slide. Restrictive diets are often advocated in the treatment of IBS, but we don't really understand their long-term effectiveness. So the goal of this study was to evaluate the long-term effect on IBS symptoms of 2 different restrictive diets within the context of a randomized controlled trial. So participants for the study were adults with IBS who had at least moderate symptom severities, and volunteers were randomized to one of 3 treatment groups, which included a low FODMAP dietary intervention, a low carbohydrate dietary intervention, or optimized medical treatment. After the intervention period, patients in the low carbohydrate arm were informed of their dietary intervention, and patients in the low FODMAP group received information about reintroducing FODMAPs, and then they came back for a 3 and 6 month follow-up visit. And the primary endpoint of interest was a reduction in the IBS symptom severity score by at least 50 points. And dietary intake was measured using 4-day food records, and they focused on analyzing energy as well as nutrient intake. So a total of 304 participants were randomized, and 294 were included in the intention to treat analyses. Dropout rates were fairly low during the intervention period, about 6% in the low FODMAP group and 5% in the low carbohydrate group. At the 6-month follow-up, dropout rates were higher, 43% in the low FODMAP group and 36% in the low carbohydrate group. When they looked at the intervention phase, they did observe a significant reduction in IBS symptom severity scores after the 4-week intervention. This data was previously presented at last year's DDW, but what they observed here was that at the 6-month follow-up, these improvements persisted, and both the low FODMAP and the low carbohydrate groups showed this effect, and there was no significant interaction. In other words, both groups had a similar change in their IBS symptom severity scores over time. At the 6-month time period, 67% in the low FODMAP group and 60% in the low carbohydrate group were still responders to treatment, and again, no significant difference between the group. Baseline dietary intake did differ from the dietary intake during intervention. The only things that did not differ were FODMAP intake for the low carbohydrate group and energy intake amongst those who did not respond to their allocated low carbohydrate group. Dietary intake during the follow-up period also did not significantly differ between responders and non-responders at 6 months. They did observe that FODMAP intake was significantly lower among responders to the low FODMAP dietary intervention at 6 months when compared to baseline, and macronutrient composition was different among responders to the low carbohydrate group at 6 months compared to baseline. So in conclusion, both the low FODMAP group, FODMAP intervention and low carbohydrate dietary interventions were effective in relieving symptoms in patients with IBS, and this effect persisted long term. There were a few differences noted between responders and non-responders with regards to diet, but responders appeared to have altered their diets more. And predictors of responders, predictors of adherence should be identified to try to personalize dietary treatments for this heterogeneous patient population. The strengths and limitations, the major strength of this is that this is a long-term follow-up of a dietary intervention trial, had a very large sample size, and the actual intervention was blinded. There are some limitations. They didn't present all the data on nutrient intake, so micronutrient data may also be relevant. There was an unblinding that occurred after the intervention phase, and we did see quite a large dropout at 6 months. And again, the other thing to think about is that adherence to dietary interventions may have correlations with responsiveness for reasons other than dietary changes alone. That's it. Thanks.
Thank you, Dr. Shin, for a great talk. The floor is open for questions, or please write one down or send it up to the front. I guess I'll ask something not really directly related to the abstracts, but for idiopathic functional diarrhea, it's said in guidelines we should be thinking about bile acid malabsorption. I think most of us just empirically do a trial of treatment. Is there a commercially available test for bile acids in the stool in the US now?
There is a commercially available test. The one that I'm familiar with is the test at Mayo Clinic, which is a send-out test. Yeah. So if a practice is interested, they can set up an actual send out to Mayo. You actually have to ship the sample overnight, and then they will process it and provide the results. The cost of that test is about $200, at least from what we've experienced. But because using bile acid binders empirically is convenient enough, I don't see that it's used that often.
Okay, so just empiric treatment. We have a couple questions here. Although this is the upper GI tract, but are you aware of a recent abstract regarding evidence there is a deficit of certain brain chemical resulting in satiety in normal BMI patients, missing in obese BMI patients, persisting even with weight loss? If you're aware of it.
I am not aware of that abstract. I apologize.
That's okay. Dr. Metz?
Do you know in the UCLA imaging for sample-to-sample variation in the individual images, I take it was aggregate rather than individual images? Is there a sampling error, sample-to-sample?
You mean for the mucosal biopsy specimens?
That's correct, yeah. When you actually look at the actual image from sample 1 versus sample 2 versus sample 3, it's just curiosity. You probably don't know, or they didn't address that.
In terms of, I don't know that they describe their data in terms of individual to individual variability within IBS or healthy controls. I don't have that information, unfortunately, but that's a good question.
Okay, another question from the group. How often do you swallow a vibrating capsule? And I think you answered this in the abstracts, but how do you measure abdominal distress in mice?
So the vibrating capsule, at least in the original RCTs, were swallowed like 5 days a week. And you would swallow it in the evening, so once daily. You can now purchase the vibrating capsule through the company. It's about $90. And even though the original trials did 5 days a week, patients may not necessarily use it as frequently, again, thinking about cost. Okay. And abdominal distress. Common approach to measurement is the visceromotor response, or the reflexes to colorectal distension, and that's usually performed using a catheter, a manometry catheter.
Second microphone.
Just a comment. I'm Angelina Collins from UC San Diego. Prometheus also has a bile acid test as well. Also would be sent out. I don't know how it equates to the Mayo score, but it's called 7C4. It's probably equivalent cost-wise as well.
Thank you.
Yes, and 7C4 is a blood test. And then I think some hospitals can probably measure 7C4 as well, but that does have diurnal variation. So patients have to come in fasting, and you have to get an AM blood draw, at least the way that we were taught to do it. But the stool test, I believe, is only available through Mayo.
Maybe one more question. So you're obviously at an academic center. You have access to various clinicians to help you with your difficult IBS patients, but digital health really seems like a potential breakthrough for people in the community. Do you have like a litany of apps that you recommend now, or?
The one app that I have tried using is the Nerva app, if others have heard about that. It is more of like an online hypnotherapy program, and patients can go up there and kind of add some details about themselves to set up their own profile. But this is something that might be useful as a tool, especially for clinicians who don't necessarily have access to, trained GI psychologists. Even within an academic center, access to GI psychologists can still be fairly limited because the number of patients and the number of trained clinicians aren't really balanced.
Thank you, Dr. Shin.